Our next talk is determining a threshold toe-arm index for wound healing potential in patients undergoing vascular intervention from the group at UC Davis with Dr. Luong, Brown, and Kwong. And presenting for the group is
Brian Luong.
Brian Luong. Brian, you're a resident, or?
I'm an undergraduate student.
Okay, so Brian is Mr. Brian Luong. He's an undergraduate student, amazingly enough. So let's.
All right, thank you so much, everyone. Thank you so much for the program coordinators for the privilege of the podium tonight. My name is Brian Luong, and I'll be presenting my study that I conducted with Dr. Mimi Kwong of UC Davis Health, and I am an undergraduate student of the University of California, Davis. I have no relevant disclosures. So the SBS Global Vascular Guidelines recommend the usage of the Wi-Fi classification system in guiding treatment for patients with chronic limb-threatening ischemia. The Wi-Fi classification system is very effective has been shown to be very effective in predicting wound outcomes, including the likelihood of amputation. However, the Wi-Fi scoring system may be very impractical to use in non-specialty settings where these patients are often initially evaluated. In a recently published study by Dr. DeLosa and colleagues, even after being educated on how to use the Wi-Fi system, physicians reported persistent discomfort in using the more subjective aspects of the Wi-Fi system, including in determining a wound grade. They also reported persistent discomfort in implementing Wi-Fi into their practices and lacked societal support in including Wi-Fi into their practices. Therefore, usage of more simple measures, such as the ankle brachial index, remains valuable to non-vascular providers to quickly triage a chronic wound and refer those that need urgent care to vascular. However, interpretation of an ankle brachial index may be difficult for some patients in those that where the values may be artificially normalized in those with arterial wall calcification. Therefore, the digital pressures are less prone to medial calcinosis and are thus less likely to be incompressible. Therefore, the toe-arm index provides a more simple data point for which we could use to identify the need for and the urgency of vascular care. However, the value of the toe-arm index as a clinical indicator of wound healing potential has not been well established in the published literature. We sought to investigate this using a retrospective review of our institutional data. We looked at patients over a period of 5 years with lower extremity wounds who had at least one valid postoperative toe-arm index value. We extracted data on patient demographics, comorbidities, pre- and postoperative toe-arm indices, Wi-Fi scores, and procedural factors. The primary outcome study was wound healing without major amputation at 1 month, 6 months, and 1 year after revascularization. And the secondary outcome was wound healing without any amputation at the same time points above. So overall, in our study cohort, we had 173 patients. The majority of these patients were male and white. Over 3/4 of our patients were noted to have diabetes, and over 1/2 were noted to have coronary artery disease. The mean Wi-Fi score was 3.02. 77.5% of our patients had underwent endovascular revascularization, and the mean preoperative toe-arm index was 0.21. The mean postoperative toe-arm index was higher at 0.36. 55% of our patients had healed at 6 months, and 86% of our patients had healed at 1 year. 46.2% of our patients had required an amputation, with the majority of these amputations being at the toe and transmetatarsal levels. And due to continued poor wound healing, 15% of our patients required a subsequent amputation, with half of these amputations being at the below knee and above knee levels. And overall, 40% of our patients had healed at 1 year without any amputation, and 65% of our patients had healed at 1 year without major amputation. And the median healing time for all of our patients were 132 days. As for patients that had healed without major amputation at 1 year, we did not find any significant differences in age, gender, race, smoking status, or prevalence of comorbidities. As expected, those who had healed at 1 year without major amputation had a lower mean Wi-Fi score with a mean of 2.84 versus a mean of 3.35 for those who did not heal. And additionally, we found that those who had healed had a higher postoperative toe-arm index with a mean of 0.38 versus a mean of 0.30 for those who did not heal. As for patients who had healed their wound without any amputation at 1 year, we saw some significant differences. For example, those who had healed at 1 year without any amputation were more likely to be white. They also had lower rates of diabetes and lower rates of chronic kidney disease. Additionally, we also found that patients who had healed without any amputation at 1 year were more likely to undergo open surgical intervention as compared to endovascular revascularization. Additionally, as expected, we also noted that patients who had healed had a lower mean Wi-Fi score and a higher postoperative toe-arm index, although the latter is not significant. Here you can see the receiver operating curve constructed for the postoperative toe-arm index as a predictor of wound healing without need for major amputation. The UDIN index calculated identified a threshold toe-arm index value that optimized both sensitivity and specificity. This identified a toe-arm index value of 0.3. We then used this value as a starting point to which we identified the varying sensitivities and specificities around this middle value. In our study, we found that toe-arm index was an independent predictor of wound healing without need for major amputation. This suggests that there may be utility of this in prognosticating healing potential in the setting of chronic wounds. However, the predictive power of this is poor based on our AUC value of 0.62. Potential reasons for this could be the significant heterogeneity of our patient population. Chronic limb-threatening ischemia is a heterogeneous disease. Patients with the same toe-arm index value may have dramatically different factors that contribute to their non-healing wounds. Only some of these factors were accounted for in our study. Another additional factor could be that toe-arm index alone may not be enough to predict wound healing. In our study, we found that the toe-arm index threshold of 0.3 optimized both sensitivity and specificity. However, different thresholds may be warranted depending on the clinical scenario. For example, in our study, we found that the value of 0.2 offered reasonable sensitivity, while the value of 0.4 offered reasonable specificity. Additional investigation is required to further validate these potential threshold values, potentially using a more uniform patient cohort. Additionally, our study does provide evidence to support the use of the toe-arm index over the ankle brachial index. The UDIN index calculated identified the same threshold value for both diabetic patients and non-diabetic patients. And this reproducibility lends strength to the consistency of the toe-arm index for diabetic patients, where ankle brachial index may be less reliable. Overall, our study does have limitations. We conducted a retrospective single institution study, which limits our generalizability. We did not account for certain factors such as wound care regimen, frequency of care. And so therefore, future studies should focus on investigating the prognostic power of the toe-arm index in larger multi-institutional cohorts. Thank you so much. I'll leave the floor open for any questions and any comments.
Dr. Rajani.
Hey, great job. At the student level, I mean, just an amazing presentation. I will criticize your mentors for letting you down on two fronts. One, we don't wear jackets at this meeting, so feel free to be more casual next time. My question has to do with, you've done a great job of looking at one side of the coin, right? You looked at everyone who got revascularized and did they heal, but as you know, much of the Wi-Fi data to date has some inferences to who doesn't benefit from revascularization. Have you changed your practice based on this data to use TAI to suggest that some patients don't need revascularization, or are you still sticking with what we already know about Wi-Fi predicting benefit of revascularization?
That's a really good question. So the Wi-Fi classification system is definitely a very comprehensive system of assessing a chronic wound. For example, it puts into account the wound grade, it puts into account the foot ischemia, it puts into account the infection level. However, for a lot of non-specialty clinics, non-specialty physicians, especially in the primary care setting or the ER setting where these patients are often initially evaluated, a lot of these physicians have expressed a lot of discomfort in utilizing the Wi-Fi system, especially more of its more subjective aspects. And so in using the toe-arm index value as a potential predictor of wound healing, we can resolve this issue by providing a more simple data point that a lot of these physicians can utilize to assess the state of these patients experiencing chronic limb-threatening ischemia. Not to say that the toe-arm index is better than the Wi-Fi score. The Wi-Fi score is definitely a very comprehensive system, but hopefully with the study and potentially future studies that investigate the prognostic power of the toe-arm index, we can use the Wi-Fi score in conjunction with the toe-arm index to hopefully provide a more holistic view of a patient's condition.
Thanks. Great job answering the question. I would encourage you in the manuscript to maybe dive into the idea of what it means to only study patients who are revascularized as to all comers who are coming even before revascularization is contemplated.
Dr. McGee.
Great job. So I was curious, because most of us use, absolute toe pressure as opposed to toe brachial index. Did you look at that independently? It's certainly possible that the actual nominal pressure, irrespective of the arm pressure, may be more predictive. I was curious if you looked at the two separately.
Yeah, thank you so much for that question. Could you repeat that again, please?
Yeah, so I was curious if you looked at whether or not toe arm index, as you described it here, or the nominal toe pressure, not the index, was more predictive of wound healing. Or did you look at that at all?
I believe my mentor, Dr. Kwong, could answer that question.
Sure.
So we did look at toe pressure because we actually used it to calculate the Wi-Fi. So that's where we based off of our Wi-Fi scores from when we went back to calculate it. We didn't specifically study that as one of these predictors of wound healing, but our thought was that, that the index is something that is normalized and easier to kind of compare across patients. We have, patients who are very hypertensive might actually have a high toe pressure that if you actually calculate out the index, they're considered considered severely abnormal, and so we thought that it might be a more objective measure. And it's actually interesting when we were thinking about it, and we did a literature search looking back. There's not a lot published looking at the index as a predictor. There are actually quite a few studies looking at absolute pressure. So we also thought secondarily it would be nice to contribute to the data looking at toe arm index specifically as a predictor of wound healing.
Yeah, I just was going to say, if you've done that already, then it'd be super additive to the literature. If you could show that toe brachial index was actually more predictive than absolute toe pressure, that'd be really interesting.
Yeah, I enjoyed your talk. I was going to ask along the same lines. I think a lot of us still use toe pressure, and so I think it's something that you should have in your manuscript. You came with this cutoff of 0.3 as being your more predictive, but could you actually, if we're going to use the TBI, do you have a number or a threshold where we say, boy, it's never going to heal, and then a threshold where you can say, yes, this is very high sensitivity? Because 0.3 just seems like when the podiatrist calls and says, is this going to heal, the TBI of 0.3, I still don't feel like I'm going to tell them yes or no, right? So I think trying to find a better threshold there, or were you able to find thresholds where you could say that most likely this is going to heal and this isn't?
Yeah, thank you so much for your comment. Yeah, definitely. In our study was definitely limited by the limited sample size, by the fact that we had a single institution nature, and so future studies should definitely focus on having more patients, more multi-institutional cohorts, in order to sort of isolate a better toe arm index threshold that we can use to predict wound healing.
Yeah, I think to kind of touch on that, we used the UDIN index to kind of identify where to start, even looking at the different sensitivities and specificities. And we saw about 0.4 had okay sensitivity, is about 77%, which is not great. But it's hard because we're kind of asking that to be the sole predictor of wound healing, and it's probably not the only thing that's going to be able to predict it. And we had a very, like Brian was saying, a very heterogeneous patient cohort, and so hopefully, if we can kind of simplify the patient cohort and really isolate the effect of the toe arm index, we might be able to have more certainty with our cutoff point. But I think 0.4 for us was a pretty reasonable specificity for wound healing.